Assalamu alaikum. Welcome everyone in our second day pharmacy research day. First, I would like to welcome you all, and I would like to welcome our attendees and our judges and our speakers today. First, I would like to congratulate the winner yesterday. You did a great job, and we really enjoyed the lecture or the research that was presented yesterday. Also, I would like to thank the moderator yesterday, the speakers, and also the judge. Today, inshallah, it will be very interesting, and we have a lot of speakers with very interesting topics. But first, I would like to introduce our judges today. First, we have Dr. Hadil Al-Kfedi. She's assistant professor at Clinical Pharmacy Department, King Saud University. Dr. Al-Kfedi received her PhD degree in Clinical Pharmacy and Translational Science from Tufts University, United States. Dr. Al-Kfedi primary research area of interest include evidence-based methodology for a variety of clinical topics with emphasis on cardiovascular and cardio-oncology medicine, and also multiple treatment comparison and meta-epidemiological studies. In addition to research, Dr. Al-Kfedi also involved in clinical trials and regulation and monitoring of these trials. Our second judge, Dr. Mohammed Harvey, he earned his PharmD degree from King Abdulaziz University in Jeddah 2010, and he completed his PGY2 residency in pediatric from King Abdulaziz Medical City in Riyadh. Dr. Harvey is board certified in pediatric pharmacy specialty, and currently he's working as a pediatric clinical pharmacist consultant in King Abdulaziz Medical City, Jeddah. In addition, he's actively involved in multiple researches. Our third judge, Dr. Sajal Mazrou, she received her PhD degree in pharmaceutical science with focus on health economics and health service evaluation from University of Nottingham in 2018. She's currently working as an assistant professor in clinical pharmacy department, King Saud University. Dr. Mazrou authored and co-authored several peer-reviewed publications and presented her research at national and international conferences. Also, she supervised several graduation projects. Our fourth judge, Dr. Mohammed Shanawi, he had a bachelor degree in pharmaceutical science from King Saud University. His master degree in business and administration from Al Faisal University in Riyadh. He had profound administrative experience when he was at King Faisal Specialist Hospital and Research Center in Riyadh. Dr. Shanawi also had great achievement outside his organization, as he is chairing the Saudi Club for Narcotic and Control Medication since 2008 until now. So, inshallah, soon we'll start with our first speaker, but before that, just I want to emphasize on very important things that the speaker should adhere to the time, because today, mashallah, we have a very condensed schedule. So each speaker will allow for 10 minutes and 5 minutes to present and 5 minutes for question and answer session. Also, I just want to clarify something, that the judge will be responsible to control the time. So now, our first speaker, Rawa Faden, she will present her topic entitled of Histamine 2 Receptor Antagonist versus Proton Pump Inhibitor for Empirical Treatment of Nausea and Vomiting of Hospitalized Children. Dr. Rawa, you can start now.
Yes, السلام عليكم. صوتي واضح؟
Yeah, صوتك واضح. You can share the slide, please.
Okay. Okay, Assalamu alaikum. Good morning, everyone. This is Rawa Fadin, pharmacy intern, King Saud bin Abdulaziz University for Health Sciences. Today, I'll be presenting our research topic, histamine 2 receptor antagonist versus proton pump inhibitor for empirical treatment of nausea and vomiting of hospitalized children. So, as an introduction, nausea and vomiting are considered common and most distressing symptoms due to gastrointestinal and non-gastrointestinal disorders, which can lead significantly lead to impact quality of life and increase morbidity among pediatric patients. They affect length of hospitalization and overall healthcare cost and patient satisfaction. So there are several pharmacological agents are available to treat nausea and vomiting in children, including anticholinergic, antihistamine, serotonin receptor antagonists, and steroids. Also, proton pump inhibitor and histamine 2 receptor antagonists. By the mechanism of action, both proton pump inhibitors and histamine 2 receptor antagonists are effective in lowering gastric pH and treating nausea and vomiting associated with different pediatric disease states. And they have potential antiemetic properties as well as they also have properties to treat gastrointestinal symptoms by decreasing the production of gastric acidity and improve symptoms. So our research, however, using proton pump inhibitor or histamine 2 receptor antagonist for acid non-related nausea and vomiting is controversy. So our study aimed to investigate safety and efficacy of histamine 2 receptor antagonist versus proton pump inhibitor for empirical treatment of nausea and vomiting in hospitalized children. And this is a retrospective cohort study of hospitalized children who had unspecified nausea and vomiting and received acid suppressive therapy. We included patients who received acid suppressive therapy who are of 14 years old or younger, and excluded patients with GI bleeding, gastrointestinal reflux disease or gastric ulcer, or patients receiving chemotherapy, or patients have received acid suppressive therapy for less than 3 days. As our primary outcome is the complete resolution of nausea and vomiting within 3 days. That means 0 episodes of nausea and vomiting in the first 72 hours. The secondary outcome was the frequency of rescue medication use and number of vomited since starting the acid suppressive therapy and adverse drug reaction. So all medications, proton pump inhibitors and histamine 2 receptor antagonists were pre-specified dosing as per child weight. We had only available histamine 2 receptor antagonists as oral and parenteral ranitidine, and the BPI group oral omeprazole and parenteral esomeprazole. So the study was first approved and by the IRB office of King Abdullah International Medical Research Center and conducted at King Abdulaziz Medical City. So a total of 206 children were admitted during the study period and screened for the indication of acid suppressive therapy. Only 137 patients who had diagnosed with unspecified nausea and vomiting and also received the acid suppressive therapy were eligible for inclusion. After exclusion, the patient only 25 patients were in the histamine 2 receptor antagonist group, and 37 patients were in the proton pump inhibitor group. As shown in the table number 1, there was no statistically significant differences between the two groups, and majority of the subjects were male, and with average age of 3 to 4 years, and respectively. So 3 to 4 years and 4 to 3 years for histamine 2 receptor and proton pump inhibitors patients respectively. So dehydration as a complication of nausea and vomiting was reported in 12 children. However, there was no statistically significant between the two groups. And 62 patients were, as we mentioned, 62 patients. Sorry, a total of the patients included in the analysis were 62 patients included in the study, and overall for 54 of all patients had complete resolution within 3 days of acid suppressive therapy, with no significant difference between the two groups, and met the primary outcome. And as shown in the table number 2, overall the primary outcome, the 87% children who met the primary outcome, and with both groups showed no significant difference in complete resolution with nausea and vomiting within 3 days. And as shown in the table number 3, of those achieving the primary outcomes, the number of reported nausea and vomiting since starting the acid suppressive therapy until complete resolution were similar between the two groups. And overall, 14 patients, required rescue medication with granistrone. And in addition, there was also an insignificant difference between the two groups in the total number of the doses, granistrone doses required during the study period. So our study revealed that the proton pump inhibitor was superior, non-superior, and non-inferior than histamine 2 receptor antagonist in complete resolution of nausea and vomiting within 3 days of acid suppressive therapy among pediatric patients. The results for other secondary endpoint also show no superiority or inferiority for proton pump inhibitor, and two of the patients had side effects due to ranitidine, which showed in case report as a rare drug reactions. So we can conclude that both PPIs and histamine 2 receptor antagonists were effective in treating unspecified nausea and vomiting in hospitalized children, and the selection of either of agents should be based on other factors such as cost. And that's all. Thank you.
Thank you, Ra, for this nice presentation. I have a question here. Can you tell me what this type of test did you use to compare between the groups? You say there is a p-value and there is significant difference or not. So what type of test did you use here?
As mentioned or shown in the table number 1, the statistical test used was a Fisher exact test, and also as well as in the table number 3, the p-value was also representing the Fisher exact test.
Okay, can you give me? I'm sorry. Yeah.
And the last finding, the number of times of rescue therapy administered, we used t-tests.
Okay. Yeah, I see it was a continuous variable. But can you give me one major limitation of your research project?
We have, it's a single center study, and also we had small sample size of 62 patients.
Okay. Yeah, it's small sample size, and you only compared PPI and H receptor antagonists rather than maybe not users and non-users of acid suppressive therapy. But I think it was overall good. It's a good research project. These are my questions. Maybe Dr. Mohammed have more questions.
Thank you.
يعطيك العافية رواء. Good presentation. But I have a couple of questions. Did the patient receive any type of antiemetics during the course of admission, alongside with PPI or acid suppressive agents, regardless of risdiplam? Did they receive any metoclopramide or domperidone during the admission or during the course of vomiting?
No, during the study period, they only received granisetron as rescue medication.
But during the admission or during the first episode of vomiting, they didn't receive any other antiemetic?
No, most of the patients received the acid suppressive therapy on admission.
Okay.
So from the start of from the admission.
طيب. Did you look for the cause of nausea and vomiting in those patients, or it was non-specific?
It was non-specific. This is actually the aim of the study.
Okay. How did you measure the safety of both medications?
We followed the side effect of the patient. If the patients had using either of medication had any side effect of these medications, such as thrombocytopenia, diarrhea.
And so you just only relied on the labs and nursing notes?
Yes. All data collected from the medical record.
Okay. Excellent. Thank you.
Thank you so much.
Thank you, Dr. Rawa. Now we'll move to our second speaker, Dr. Khazra Sultana. She will present for us validation and psychometric properties of Arabic version of book anticoagulation satisfaction scales.
Assalamu alaikum. Can you hear me?
Yes, we can hear you.
Can you see my presentation?
Yes.
Just one second. Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you to the Pharmacy Research Committee for giving me this opportunity to present my project, Validation and Psychometric Properties of the Arabic version of the Duke Anticoagulation Satisfaction Scale. This will be the outline of my presentation. I will just say a couple of lines on the background, the aims of the study, the methods used, what were our results, the limitations and conclusions. So anticoagulants are also called blood thinners used to treat and prevent blood clots. Vitamin K antagonist, warfarin, is the most commonly used, and it is prescribed mostly to patients diagnosed with atrial fibrillation and to treat different types of venous thromboembolic disorders like pulmonary embolism and deep vein thrombosis. In clinical practice, measuring health-related quality of life and satisfaction with warfarin therapy will facilitate interventions to maintain adequate anticoagulation and adherence to treatment. To study the health-related quality of life of patients on warfarin, different types of instruments are available. These tools can be a generic scale like the 36-item short form or the 12-item short form or the Euro EQ 5D5L, or condition-specific scales like the Duke Anticoagulation Satisfaction Scale, which was developed by Samsa et al. So the DAS was initially developed in English, and so far it has been translated and validated in Greek, Brazilian Portuguese, Malay, Turkish, and Maltese languages. To date, there does not exist a linguistically validated Arabic version of the DAS scale in the literature. Our study aimed to translate and validate the DAS instrument into the Arabic language. So the original DAS instrument, it includes 25 items which are addressing 3 dimensions. These are the first, limitations, which has got 9 items, hassle and inconvenience, 8 items, and the psychological impact, which is divided into 5 positive items and 3 negative items while the patient is on anticoagulation. So each question on the DAS scale is answered on a 7-point Likert scale with the following options: not at all, a little, somewhat, moderately, quite a bit, a lot, and very much. And these indicate 1, 2, and 3 are the scores that are used for each of the responses. If an item is not applied, then the patient is asked to choose the option not at all. 6 items are reverse coded before the analysis in the scale. The final score ranges from 25 to 175 with lower scores indicating higher satisfaction. For the Arabic version of DAS, cultural adaptation was done by MAPI Group Services. MAPI Group has been known as the leading authority in linguistic validation and cross-cultural adaptation. It develops scientifically cross-cultural translations of scientific tools. We use the Euro 5D5L instrument to assess the health-related quality of life. This instrument was also administered to assess the known group validity while validating the instrument. So the Euro Q5D5L incorporates 5 possible levels to 5 dimensions. The dimensions are mobility, self-care, usual activities, pain and discomfort, anxiety and depression. Then it has got a EQ VAS that lists the patient's health using a visual analog scale with 2 endpoints. Best imaginable health is scored to 100 and worst imaginable health is scored as 0. This instrument has been translated and validated in the Arabic language and is available to use online. So the results. In our study, 505 patients completed the Arabic version of the DAS and the Euro Q5D5L on warfarin and apixaban for various clinical conditions. The first step for us was to carry out the confirmatory factor analysis. We used the software AMOS for the structural equation modeling to carry out our confirmatory factor analysis. For the analysis, out of the 505 patients, we had 435 complete responses. So only 439 responses were included. The results of the CFA in our study did not confirm the factor structure of the original instrument, which was divided into limitations, hassles and inconvenience, and psychological impact. So our factor structure did not, the results of our CFA did not conform to this factor structure. So for the Arabic version of DAS, the root mean standard error of approximation and the standardized root mean residual were all above the acceptable value. As you can see that this should be less than 0.08 RMSEA and SRMR should be less than 0.01. Whereas the indices for goodness of fit were all above the adequate fit level. They were all below the adequate fit level. As you can see, for an acceptable model, this values have to be greater than 0.9. Hence, since our factor structure didn't conform to the original factor structure, the next step was to carry out the exploratory factor analysis. We use the principal component analysis with Varimax rotation using Kaiser normalization. Initially, we had a factor structure with 5 domains and we had 5 eigenvalues above 1. We did not consider the factors, the 4 factor structure or the 5 factor structure because there were too many cross loadings amongst the factors. Finally, we finalized the 3-dimensional factor structure with 22 items that were limitations, positive impact, and negative impact subscale. So these are the 22 items which were finalized. 3 of the items from the 25 items were deleted as they had a factor loading less than 0.4. So as you can see in our factor structure, which we had with negative, limitations, and positive scale, the minimum factor loading was 0.4. So after we got the factor structure with the 3 factors, we assessed the internal consistency of the DAS, where we found that it was good with Cronbach alpha coefficient of 0.88, for the overall DAS score, and 0.82 for the limitation subscale, which had 7 items, and 0.78 for the positive subscale with 6 items, and 0.84 for the negative scale with 9 items. Now, for the Arabic version, the correlation coefficient between the overall DAS score and the limitation subscale is 0.792. The total DAS score and the negative impact subscale was 0.851, and the DAS score with the positive impact subscale was 0.799. We assessed the construct validity of our instrument with the help of exploratory factor analysis, and hence we were able to determine the convergent and the divergent validity. As you can see here, first we calculated the correlation estimate between the different factors that were obtained, that is between the limits and the negative subscale, negative and the positive, limits and the positive. So this is the correlation estimate we got. To determine the divergent validity of our scale, the square root of the average variance extracted must be greater than the correlation estimate. As you can see that these values are greater than the correlation estimate, hence we were able to establish divergent validity for our scale. With respect to convergent validity, the average variance extracted must be greater than 0.5. Hence, you can see that since for all our subscales, the value is greater than 0.5, we were able to establish the convergent validity. We then went on to assess the known group validity by using a point serial. We used 2 types of correlation. We used Pearson's correlation to check the correlation between the total DAS score, the 3 subscales with the different demographic characteristics, the clinical characteristics, and the different dimensions of the EuroQ5DL. So for the categorical variables, we will use the point serial birelation correlation, and for the continuous variables, we use the Pearson's correlation coefficient. As you can see in this table that our instrument, it consistently correlated with all the dimensions of the EuroQ5L, and also it significantly correlated with the gender, and hence we were able to establish the known group validity. So the limitations of our study, in our population we did not have the right amount of bilingual people. Hence the original version of the instrument was not evaluated along with the Arabic version. We were not able to collect data on patients' INR and bleeding events. Therefore, we were not able to establish if most of the patients adhered to their therapy, though they reported satisfaction with their treatment. Patients were enrolled from a large government facility in Saudi Arabia. These results cannot be generalized to all anticoagulated patients in the Arab world. More studies need to be conducted in other types of healthcare systems from different regions in the Arab world to assess the validity and reliability of the Arabic version of the DAS. In conclusion, in our study, DAS was translated in Arabic and tested in 439 patients, which is the largest sample population as compared with all the previous studies. The Arabic version showed excellent reliability and validity. These findings are comparable to the original English version. The results of our study suggest that Arabic version of DAS is a valid and reliable instrument to assess the level of satisfaction of Arabic-speaking anticoagulated patients. It can be used by healthcare professionals working in other settings of anticoagulation clinics for future research studies, assessing patients' satisfactions and limitations to the anticoagulation treatment. I would like to thank the PI of the study, Dr. Maha Al-Ammari, and all the other members of the study team for helping us in collecting the data. And our study has been published already in the Frontiers of Pharmacology. Thank you. Hello? Hello? Hello?
Hello, thank you.
Were you able to hear my presentation?
Yes, thank you. It was an excellent, very thorough presentation. Thank you for all the details that you have presented. is this, can you tell me how the added value of this scale once translated to Arabic in clinical practice?
As you know that there are a lot of patients which are on the anticoagulation treatment of warfarin, and we need to test their quality of life. So this is normally the other very generic forms like I mentioned, SF36 or 12 short forms are used. And this is a condition specific. So it will assess exactly what is the quality of life of patients who are taking warfarin, and the questions are very specific. So since for all the patients who speak the Arabic language, there wasn't a translated and validated version. So by providing this version, now you will be able to rightly assess what is the patient feeling or how the patient's quality of life is. So based on that, you can further decide what type of action has to be taken for the patient's therapy.
Thank you.
Any other questions?
Thank you, Doctor. I don't have any questions.
Thank you so much.
Thank you, Dr. Sultana. We have a little bit modification in our schedule. Now, Dr. Fahad Al-Khuzai, he will present ethical reasoning in undergrad pharmacy student and the way forward. Dr. Fahad, you can share your slide and you can start. Dr. Fahad? Dr. Fahad?
السلام عليكم.
Dr. Fahad, can you share your slide?
الو
سامعينك.
السلام عليكم.
Do you want us to share your slide or you have it ready with you?
Yeah, I have it ready. 1 minute.
Yeah, okay, thank you. Dr. Fahad, we can share the slide from our side if you like to.
That's fine. خلاص, I'm almost done. We'll share it now. Is it clear, Doctor?
Okay, clear. You can start now.
Yes, Assalamu alaikum. My name is Fahad Al-Khuzai. I'm a pharmacist. I'm a pharmacy resident at King Faisal Specialist Hospital and Research Center in Jeddah. It's a pleasure to present this research to you, which is titled "The Ethical Reasoning in Undergraduate Pharmacy Students and the Way Forward." As a background, we can say that ethical reasoning, to define it, it's a decision-making process that involves forming judgment and what is morally right or wrong. So it forces individuals like pharmacists to weigh the benefit of their actions and the possible consequences. So anytime the pharmacist or pharmacy students face any morally questionable situation, he has to judge what is morally right to do or not. Based on Kohlberg's cognitive moral development theory, which states that any individual with ethical reasoning or has to do any ethical reasoning in any situation, he has to proceed from 6 stages of moral or cognitive moral development. In summary, this moral development can be reasonably measured or assessed using 2 methods. The first was the moral judgment interview, which is an old method and not validated enough to be used in the current climate. And the second one, which was validated in the 2000s, which was the defined. The pharmacy profession, as we know, is highly regulated and bound by ethics and code of ethics, institutional interest, and professional mannerism, which require any individual practicing this profession to have these moral judgments. Due to lack of reasoning or training in ethical reasoning, pharmacy students face these issues daily in their undergraduate school and after graduation. So we want to question, our question was to explore this ethical reasoning within the undergraduate pharmacy student and see using a qualitative thematic analysis method. So we first designed the inline questionnaire with 10 scenarios, anonymous and open-ended scenarios, encompasses various stages from their career, from undergraduate scenarios all the way to postgraduate scenarios. We use Google Docs to distribute this online questionnaire, and the participants were the 4th and 5th PharmD students in their summer training. We utilize, as I said, the thematic analysis method. The first stage was to familiarize with the data, development of codes and themes of these narratives, where we analyzed the narratives of the students. And lastly, the themes were mapped out after revision by both authors independently. The analysis was facilitated by the in vivo program, and the data saturation was formally addressed also, and the final themes were discussed between the authors. After we did the qualitative analysis, turned out that 47 students, of which were 19 were males and 28 were females, were randomly selected from the 186 responses. The reason we chose to pick only a small sample of the huge responses was that given that the qualitative study is the cumbersome and require or have data saturation in their methodology, so we opted to only choose a small sample. More than half of the participants were senior students, and after we analyzed their responses, we have identified 35 subthemes. After discussion between the authors, we finalized through the themes with overarching themes. The overarching themes were mental presence versus physical presence, social and professional responsibility, academic integrity, which was important in the research, legal obligation, moral obligation, signposting, and moral engagement and patient safety. After we analyzed all the responses, we have come to some of the recommendations mentioned in the literature. Some of the recommendations were to put ethical reasoning or put the student through ethical courses, or utilize active learning strategies to improve their ethical reasoning, or test their initial ethical reasoning. Let's say that it's the initial ethical reasoning measurement to see what are their ethical reasoning before continuing to develop it. The literature suggested to use situational judgment test and professional ethics in pharmacy tests. And some of the literature suggested that using non-traditional teaching methods like social media would improve their ethical reasoning. And lastly, we can include it in an OSCE or objective structured clinical examination. We have concluded this study that the exploratory study was consistent with the previous literature, and the students showed the level of reasoning or moral development similar to what was already mentioned in the literature. And further research studies should quantify or measure how the student will deal them with this moral situation, and how we can improve it using how it will impact their learning outcomes. With that, I would like to conclude the presentation. If anyone have any question, I will be ready to answer it, inshallah.
Thank you for this interesting presentation, Dr. Fahad. I have a question. What made you think of this research project? I really have a lot of interest in the ethics of both students and practitioners, not just students. But what made you think of this?
As a practitioner, as a pharmacist first, before a pharmacy resident, I was involved in a previous research, a qualitative research, which dealt with students, how we can facilitate English learning in pharmacy students. So this was my first exposure to qualitative studies. Through it, I discovered that most students did not have this, like the enough training in ethical reasoning. I discovered that they lack the ethical training, and and I thought that we can explore this theme, because one of the themes that was mentioned in the previous study was that they did not have training in either ethical reasoning or at that time English training. So I thought that if we can explore their ethical reasoning and how they can apply it in the practice, and from that I did the research, and alhamdulillah, I got what I would say excellent result.
Thank you for your answer.
يعطيك العافية دكتور فهد. I have actually two questions. The first questions, did the responses differ between university and university? I know you've actually selected 75 participants from all the other surveys. Did you have multiple universities that responded to you from different pharmacy schools, or actually, selected pharmacy schools?
No, it was only selected pharmacy university schools. Unfortunately, I did not have the means to expand this research. It was exploratory in nature, so I opted only to select a few universities on my regional area, and due to the huge responses, I opted also to only select a few randomly, of course. And from this sample, we can, it took almost half a year to analyze all of these responses qualitatively.
Did you have any, your questions were straight questions or scenarios for the themes?
No, it was scenarios, open-ended, and open-ended and scenarios. From the most of these scenarios were discussed with senior pharmacists before, with some of the teachers available at some universities, not all of them. And from their responses, we finalized all of these scenarios. So it wasn't randomly selected. No, the scenarios was specifically designed through asking experts in the field.
Excellent. يعطيك العافية.
الله يعافيك.
Thank you, Dr. Fahad.
You're welcome.
Now we'll move to our second speaker, Dr. Angham Sahli. She will present for us knowledge of hypertension and its impact on blood pressure control among Saudi hypertensive patients, multi-city study. Dr. Angham, you can share your slide.
Yes, sure. shared or no?
Dr. Anam, can you put it in full screen, please?
Sorry.
Your slide, put it in the full screen, please.
Okay.
Dr. Anam?
إيه. تمام دكتور ولا لسه؟
لا, we need it in the full screen. We cannot see it in the full screen.
From where?
In the PowerPoint slide, the PowerPoint presentation, you can put it in the full screen
I put it.
for us. You cannot see it in the full screen. We can share it from our side if you like.
Okay.
Okay.
This is the previous presentation. This is not my new one.
Just 1 minute until we share it from our side, and then you can start. You can unshare your slide. Anram, can you put slideshow in the lower screen?
Yeah, I put it دكتور بس مو عارفة ليه ما يظهر عندكم على إنه في السكرين.
Okay, can you stop sharing and do it again? Yeah.
الحين.
No, still we cannot see it. Okay, I think for okay, I will ask the judge if they are okay to see the slide in this way.
Okay.
It's okay by me.
Okay.
It's fine. It's fine.
Okay. خلاص, you can start, Dr. Anwar.
Okay. Good morning. I'm Angham Sahli, medical resident at National Guard. It's my pleasure to be present today in First Pharmacy Research Day. Thanks everyone for your efforts. I will talk today about our research, knowledge of hypertension and its impact on blood pressure control among Saudi hypertensive patients, multi-city study. I want to talk today, inshallah, about essential background and our aimed method we used and result and its interpretations, conclusion, limitations, and the recommendation for future research. In the background, hypertension is a common disease among patients who visit primary health care clinics in Saudi Arabia. Patients with uncontrolled hypertension will develop a lot of complication, and controlled hypertension associated with a lot of morbidity and mortality rate. Therefore, controlling its risk factor and lifestyle behavior can lead to better control of the disease. In our research, we aimed to determine the hypertensive patient's knowledge about controlling their blood pressure and to identify factors associated with developing hypertension. Yes? Hello?
The slide is freezing. Still seeing overview slide.
Can I send it to your email, Doctor?
Okay. Can you send it to the my email?
Okay. I sent it for pharmacy research email.
It's good that we have a time, so there is inshallah no delay will happen. Dr. Anram? Dr. Anram?
ايه هلا دكتور ارسلت للدكتورة مها.
Can we do a last try? Try to open it, to open the macro, the
Okay.
PowerPoint. Try to share it. Hopefully it will work. Okay, can you move the slide?
Yeah.
I think the problem started once you click on screen, because now it's freezed.
Okay.
Can you close it?
Okay.
Close the PowerPoint and reopen it again.
Okay.
Try to do full screen. Still, yes. Still. Okay, can you cancel the full screen?
Okay.
Okay, can you change the slide? Okay, now we are seeing the slide changes.
Okay.
We'll see if we get your slide in our email. We will share it, or we will continue this one.
Okay. I sent the curriculum on WhatsApp.
خلاص, we receive your slides, so stop sharing and we will share it from our side.
Okay.
Thank you. Okay, now we have the control, Dr. Angham. So just tell us when you want to advance the slide, okay?
Okay.
Okay, so
The next is Victoria.
okay, we have time, so يعني we'll start from the beginning. You have full 10 minutes, so inshallah there is no delay will happen. So you can.
Okay. Sorry for that. I will present our research knowledge of hypertension and its impact on blood pressure control among Saudi hypertensive patients multi-city study. In this presentation, I will give you essential background about hypertension, our aim from research, method we use, result and its interpretations, conclusion, limitation, and recommendation for future research. In the background, hypertension is a common disease among patients who visit primary health care. Any patient with uncontrolled hypertension will develop a lot of complications. Uncontrolled hypertension is associated with morbidity and mortality. Therefore, controlling its risk factors and lifestyle behaviors can lead to better control of the disease. Our aim in our project, we aim to determine the hypertensive patient knowledge about controlling their blood pressure and to identify factors associated with developing hypertension in Saudi Arabia. We used a cross-sectional study where we distribute an interviewer administered questionnaire to hypertensive patients aged 40 years old or more in primary healthcare centers in main 5 regions in Saudi Arabia. The estimated sample size was 384. The questionnaire, we built questionnaire, then we did a validity test. After that, we administered it to hypertensive patients. The questionnaire was contains 19 questions. We divided it to third part. First part was for demographic data. Second part was for knowledge, and the last part was for patient certifications with the information and management given by their physicians. Now I will talk about our result from our research of the 384 hypertensive patients. Dr. Layati, can you next slide? Okay, I will talk first about demographic variable. Of 384%, the most common age group was from 40 to 49, represent 36.5%, and the majority were female, represent 78%. The highest response was from Southern, represent 31.8%. Regarding the educational levels of patients, the mainly illiterate represent 30.2%. The most comorbidity associated with hypertension was diabetic, represent 32%. Regarding the percentage for adherence to treatment plan among hypertensive patients, we found 79.4% say that they adhere to their management plan. Regarding the patient knowledge about hypertension include risk factor, symptoms, complications, and proper reading of blood pressure. More than half represent 52.9% had poor knowledge, while only 9.1% had a good knowledge regarding hypertension. Regarding the certifications with information and management plan by their physicians, 73.4% were satisfied according to the score from 11 to 15. This table for level of knowledge, as I mentioned before. In this result, perceptions of hypertensive patients about their disease risk factors and complications. Significant number of patients, they don't believe that smoking, obesity, physical inactivity is associated with the risk factor of hypertension. Only 20% of patients believe the smoking is a risk factor for hypertension, and 40% for obesity, and 32.6% for physical inactivity. Regarding the complications, the perception of complication of the patient, we found that 46.4% and 42.7% of patients believe the stroke and cardiovascular disease is the main complication of hypertension. A small proportion believes the fusion problem and kidney disease the main complications of hypertension. In conclusion, for our research, we found hypertensive patients need more educated about their disease, which would enhance their adherence to management plan and could prevent secondary health issues. Regarding the limitations, we faced two limitations in our study. The first limitation is the possibility of a recall bias. Recall bias might have caused by nature of the survey that asked the patient to answer a question about their behaviors during the past at each clinic visit. Second limitation, the study employed descriptive statistics when they're processing the data. This method allowed to us to make summation of the data only about the subject studied, but cannot be used to generalize the finding about a large population. Our recommendations for future work and future investigation of knowledge hypertension and its relation to blood pressure control should seek to comprehend the patient's background fully, their accommodation about the disease, and how they are adherent to the management to achieve the goal of health improvement by controlling the hypertension. The most important aspect of hypertension showed in the previous study, the patient's idea about their disease and medication are one of the most important predictors of medications adherence. Yes, thank you. Any question?
Assalamu alaikum. Thank you so much for your presentation. I have a question. Can you tell me why you chose this topic? Why you think the knowledge of hypertension is important? Is there any something that indicates there's lack of efficiency in knowledge in our population?
Sorry, دكتورة إيش آخر شيء؟
Is there anything that indicates in our population there is lack of knowledge in regards to hypertension or its management or risk factors in terms of how the population perceives hypertension? So what's the thought behind this research?
Okay, thanks for your question. We select these topics because the hypertension, one of the most chronic disease. Also, in previous study done in Saudi Arabia in 2013 and 2019 showed high prevalence of hypertension. Unfortunately, in our study showed the highest prevalence of hypertension more than the previous study done in 2013. For that, the prevalence of hypertension increased year by year. We think need more educated for our population regarding the hypertension and its complications.
Okay, thank you for your answer.
يعطيك العافية دكتور أنغام. I have one question. How did you measure the adherence of hypertensive medications with the patients?
In our research?
Yes.
We put a question regarding the type of medication and the proper of blood pressure reading and the follow-up in family medicine.
I didn't understand your answer. Could you repeat it?
Okay. We asked regarding the adherence in 3 points. Regarding the proper of blood pressure reading and follow-up in chronic disease clinic and the flood of communication.
You didn't measure the refill of the medications for the patients, if the patients actually took his medication on time, about the reading of recent, especially that the patients actually, you interview the patient in the clinic. So you didn't actually correlate the reading of the blood pressure with his current situation at that time, or you didn't consider these things?
Yes, we estimated the current blood pressure in the clinic, but according to adherence for medication in the home, we mentioned in the recommendations for future research should be anyone will do a research regarding the hypertension and control should be now how the patient adherence to medications.
Okay. Right. You actually specified, you didn't specify actually the type of antihypertensive medications that the patient were taking, or you just put it as a general?
No, as a general.
Okay. Excellent. يعطيك العافية.
الله يعافيك.
Thank you, Dr. Angham. Now we'll go to our second speaker, Dr. Salwa Sahibani. She will talk about effective sacubitril valsartan on glycemic control in heart failure patient with diabetes. Dr. Salwa, you can start.
السلام عليكم.
وعليكم السلام. We can hear you. You can share your slide now.
دكتور راح أنتم تشاركوا السلايدز.
Okay. Can you forward your slides?
عفوا.
Can you send your slides?
لا.
Can you send it through WhatsApp?
دكتور أمس أوكي ثواني.
Dr. Salwa, this is your slide. Just whenever you want to advance the slide, just
Okay.
Like 3-second lag time, so you can start.
Okay. Good morning, everyone. This is Salwa Sahbani from practice resident at Prince Sultan Cardiac Center. I'm so glad to be part of this event. Today, I'm gonna present my presentation about the effect of sacubitril valsartan on glycemic control in heart failure patients with diabetes. Chronic heart failure is caused due to overactivation of both sodium and water-retaining neurohormones. Most of the primary medications used for heart failure act by reducing the effect of neurohormones on the heart to reduce morbidity and mortality. One of the neuropharmacological classes that act on neuropeptides in the neprilysin inhibitors, sacubitril in combination with valsartan. Interesting. Second, this study aimed to determine the benefits of sacubitril valsartan on glycemic levels in heart failure patients with diabetes. The methodology of this study was observational retrospective study conducted in Prince Sultan Cardiac Center in Saudi Arabia. The duration starting from January 2018 to January 2019. The study was approved from the ARB. Next, study populations. Patients with heart failure reduced ejection fraction with diabetes and age between 80 to 75 was included in the study, while patients heart failure without diabetes or age more than 75, creatinine clearance less than or equal 30, ejection fraction more than 40, or potassium more than 5 was excluded from study. The primary endpoint of my research to evaluate the effect of sacubitril valsartan on hemoglobin A1C in our patients. The secondary endpoint observes the potassium, creatinine, NT-proBNP levels, and anti-diabetic medications. The data collection was demographics, hemoglobin A1C, potassium, creatinine, NT-proBNP, and anti-diabetic medications before the administration of sacubitril valsartan and 1 to 3 months after up titration to 200 milligrams of the medication. Statistical analysis, all data recorded in pre-designed and validated Excel sheet. Data represented in valid percentage for categorical variables. Parity test used for comparing this mean at a level of significant p-value less than 0.05. About the result, patient demographics, types of treatment for diabetes. The mean was high for patients take oral hypoglycemic agents, 58.4, while the patient was in insulin 12.4 and combination 29.2. Hemoglobin A1C, there was a statistical significant difference between hemoglobin A1C level before and after use of Intersto. Before, the mean was 8.4, while the after was 7.7. Also, NT-proBNP was statistically significant. Before use of Intersto was 158, while after was 567. It was significant difference. The number of anti-diabetic medications also significant. P-value was less than 0.001 before and after use of Intersto. Unfortunately, serum creatinine and potassium level was there is no statistical significance before and after use of Intersto. As conclusion for my study, sacubitril valsartan showed a significant benefit effect on glycemic control, improvement of NT-proBNP, and reduction number of anti-diabetic medication in heart failure patients with diabetes. However, there was a non-significant change in kidney functions or potassium levels. A larger scale prospective study is requested to measure the effect of sacubitril valsartan on glycemic control. Thank you. If there is any question.
يعطيك العافية دكتورة سلوى. Excellent research ما شاء الله. طيب, I have a couple of questions. The first question is, do you have any idea about the mechanism of action of glycemic control of sacubitril or no? Or you didn't come across any mechanism of action why this combination decreased the A1C significantly?
There is no clear mechanism of action how interest can affect glycemic, but depend on hoc analysis for paradigm study was they observed that interest was affected on glycemic control. That's why we're gonna to make this research on our population.
Okay, the second question, did the reduction of glycemic control differs between oral anti-diabetic and insulin?
Not clear, no. But mainly it's both. It affects both, even patient on insulin or oral anti-glycemic.
So there was no difference between both of them?
Yeah.
Right. The last question, actually, did any patient stop the anti-diabetic as an effect of sacubitril valsartan or no? Because actually, when from your result, the minimum number of or the minimum result of A1C was 5.9 or 5 point something. So did any patients actually stopped their anti-diabetic medication during the course of this therapy or no?
Stopped mean 100% it's not on anti-diabetic medication?
Yes.
No, just stop 1 or 2 anti-diabetic, but all of the medication, no.
Excellent. Thank you very much.
Welcome.
Assalamu alaikum. Thank you so much for your presentation. I think it was really a nice project to listen to. I have a question. Also, you said you think like the difference after up titration. So you mean that after patients reached the desired dose, and what was that dose you were aiming for?
We aim to 200 milligram of Entresto. Yeah, up titration takes 1 to 3 months.
And did they all reach that dose, the target dose?
Yeah, any patient not reach this dose, we exclude him because of renal or any issue with Entresto.
Okay, thank you.
Welcome.
Thank you, Dr. Salwa. Thank you for our judge, Dr. Adil and Dr. Mohammed. Now will join us Dr. Mohammed Al-Shanawi and Dr. Sajal Mazroor. They will be our judge now. And also Dr. Marwa Barnawi, she will present for us clinical and cost-benefit analysis of antibiotic against urinary tract infection due to extended spectrum beta-lactamase producing Enterobacteriaceae. Dr. Marwa, you can share your slide.
Okay, thank you. I can't because you currently sharing. It's visible now?
Yes, we can see it. Yeah, okay. Yeah, you can start.
Okay. Assalamu alaikum. Good morning, everyone. I'm Marwa Barnawi, a pharmacy resident at Johns Hopkins Aramco Healthcare R2. Today, I will present my BGY1 research project, which titled as Clinical and Cost-Benefit Analysis of Antibiotic Against Urinary Tract Infection Due to Extended Spectrum Beta-Lactamase Producing Enterobacteriaceae. background, urinary tract infection are the most common infectious disease in both hospital and community setting, which leading to increased use of health resource. And extended spectrum beta-lactamase producing Enterobacteriaceae is one of the most bacterial resistant among gram-negative organisms, which leading to inactivation of cephalosporin, penicillin, and azithromycin in treatment of UTI due to ESBL. The overall preference was 20% for this resistance based on popular SMART study, which aimed to evaluate the global preference of antibiotic resistance over 10 years. So, with increasing the rate of extended spectrum beta-lactamase producing Enterobacteriaceae to this alarming level, leading to limiting option of effective antibiotic to be used for treatment of UTI, as well as lack of pharmacoeconomic value studies. This study aimed to evaluate the impact of different regimen of UTI caused by ESBL on clinical and economic outcome. Actually, this study is unique. No published study yet with the same outcome, especially at level of pharmacoeconomic. Our primary outcome were to measure rate of clinical cure and incremental cost-effectiveness ratio between the used antibiotic, as well as rate of microbiological eradication, length of stay, and 30-day readmission as secondary outcome. So, our method was a retrospective cohort study conducting among patients admitted to Johns Hopkins Aramco Healthcare between January 2018 and March 2020. We include all patients. We include all adult patients admitted to hospital for at least 2 days and confirmed diagnosed with UTI due to ESBL. And we exclude all patients with other infection in addition to UTI and patients with polymicrobial UTI as well as pregnant women. The clinical cure in our study defined as the resolution of sign and symptom of infection, cost-effectiveness therapy defined as the regimen with lowest cost-effectiveness ratio, and data regarding demographic, laboratory, and clinically collecting from electronic medical record. As well as the financial data obtained from the accounting department of Johns Hopkins Aramco Healthcare. At level of data analysis, we use SPSS program and outcome variable presented as median. Chi-square tests were used to categorical variable, and Mann-Whitney used to compare continuous variable. The incremental cost-effectiveness ratio was calculated to determine cost-effectiveness based on the primary outcome and cost of antibiotic. We considered result is statistically significant by p-value less than 0.5. Okay, at level of our result, 81 patients, including to our study, 68 patients received carbapenem, which was meropenem or imipenem, and just 12 patients received ciprofloxacin. There was no significant difference in baseline characteristic between our population, but most of patients were female, and the majority of patients admitted to medical ward rather than ICU as case of cystitis due to E. coli. Okay, at level of our primary outcome, all patients admitted to this study were cured, but there is no significant difference between the study group as the p-value is 0.15, as well as no significant difference regarding microbiological eradication and length of stay. But there is significant difference in readmission due to UTI by p-value 0.01. Regarding to our effectiveness, cost effectiveness outcome, the incremental cost effectiveness ratio were minus 9.12, which means that ciprofloxacin has positive cost effectiveness ratio in present of clinical cure as comparison with carbapenem. So the conclusion is ciprofloxacin has positive cost effectiveness ratio in present of clinical cure rate in comparison with carbapenem for treatment of urinary tract infection due to ESBL, as well as it has lower risk of 30-day readmission. But due to of small sample size of this study, which considered as limitation, we planning to further data collection in order to confirm the validity. Thank you. Hello? Hello?
يعطيك العافية دكتورة مروة.
I think anyone hear me?
Yes, we can hear you. We can hear you.
السلام عليكم. يعطيك العافية دكتورة مروة.
أهلا وعليكم السلام ورحمة الله.
Thank you. Maybe I will start questioning and I will give maybe the questions to my colleague, Dr. Saja. Doctora, do you really believe that more than 2 years study, retrospective, and just only 81 patients that were met the criteria of the research? Is this a reasonable number to you?
Okay. Based on the duration of the study, we found just 81 patients matched our inclusion criteria. So we planning to extend the duration of the study to end of 2020, December 2020, in order to collect more sample size and validate the result.
Okay, great. Thank you. My second question is regarding the number of patients. Again, do you really find that patients that they received ciprofloxacin were just only 12 patients, were compared to almost 69 patients that they received carbapenems?
Yeah.
Is this a good reason for or give you a good indicator about the readmission rate, which is was the most beneficial thing for your research and the conclusion to use the ciprofloxacin? That maybe those numbers are not really indicating a right sample size, because almost 70 it's more than 7 times, or almost more than 6 times in the carbapenems more than the ciprofloxacin.
Actually, I don't detect your question.
The sample of the patients that you took, 69 or almost 70 patients received carbapenem, right? And just only 12 patients received ciprofloxacin, right?
Yeah.
Is this for you is a good number that to compare 12 patients to almost 70 patients for the readmission reasons?
Regarding to readmission.
Yes.
Actually, we considered it as the weak point for our study, and We obtained this data from 25 patients. Just actually, I don't understand, but
maybe
in
Dr. Saja, do you have any
in conclusion, this study is the limitation of our study is low sample size. Ciprofloxacin group, so we will be planning to collect more patients in order to validate the result.
Okay, great. Thank you.
Welcome.
Dr. Saja.
Assalamu alaikum, ya Marwa.
أهلا وعليكم السلام دكتور سعيد.
Thank you so much for this presentation. Actually, I will not take very long, but can you move to the ICER table, please?
Okay. Yes.
Yes. So this is a cost-benefit study, and
yes.
And I'm not sure why you are using cost-benefit, because it is a cost-effectiveness analysis. This is the first comment. The second thing is that you only calculated the medication cost. Did you calculate the cost of hospitalization, the cost of nursing, the other direct costs?
Yes, we calculate cost of hospitalization in addition to cost of medications.
Okay, but in this table, to me and to all audience, it is the only medication cost. I'm not sure because to me this is you said we calculated all direct costs, but in this table it is only medication cost. That's why I was quite confused.
Okay, we just did the incremental cost effectiveness ratio, including the hospitalization cost, not just medication cost.
Okay.
I mentioned the medication cost as because it's our related as pharmacists.
Okay, but for if you want to present this in other conferences, you need to write direct medical cost. So this is the right terminology to use. Okay, I have a second question. How did you calculate the clinical cure? You said you define clinical cure as reduction in signs and symptoms, right?
Yes.
So did you calculate the days needed to be symptom free?
We calculate yes the length of a stay and sign of symptom of first we calculate the sign of symptom of infection like internal inflammatory marker and the temperature.
Okay, but how did you translate this into something numerical? So
yes.
if you want to calculate ICER, you need to have something. You need to have a numbers. So did you calculate the days needed to be symptoms free?
Yes. Yes.
Okay. 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 Thank you so much. I don't have further questions.
Okay. Thank you.
Thank you, Dr. Marwa. Now we'll move to our second speaker, Dr. Hind Al-Khalifi. She will present for us incidence and risk factor of carbapenem resistant Enterobacteriaceae infection in intensive care unit matched case control study. Dr. Hind, you can start. You can share your slide.
Okay. السلام عليكم جميعا.
السلام.
السلام ورحمة الله.
Can you see my slides?
No, we cannot see it. Do you want us to share us from our side?
لا ممكن عشان أنت فاتح الشير حقك. Can you see it now?
Yes, we can see it. Can you put it in full screen?
Yeah, sure. Is it good now?
Yes, yes. You can.
Okay, assalamu alaikum. Good morning, all. My name is Hind Khlafi. I'm fresh graduate from Princess Noura University and currently working at Tobacco company. I would like to share my graduation research with you, which is about incidence and risk factors of carbapenem-resistant enterobacterious infection in intensive care units at King Abdulaziz Medical City. First of all, carbapenem-resistant has been widely disseminated across the countries for the past couple of years, and it has been linked to a high morbidity and mortality rate, especially in the ICU. But the risk factors and the incidence rate of the ICUs of carbapenem-resistant in Saudi Arabia hasn't been fully understood. So our study aims to determine the incidence, risk factors, and patient outcomes associated with a CRE infection among all patients admitted to the ICU at King Abdulaziz Medical City. For the method, our study was a retrospective matched case control study of a patient admitted to the ICU units in King Abdulaziz Medical City. Our inclusion criteria was all patients admitted to the ICU who has at least one positive culture of Enterobacterias, whether it's sensitive or resistant. We excluded patients who had a positive culture of Enterobacterias before the admission of the ICU. Patients were randomly selected from a pool of carbapenem-sensitive subjects in a ratio of 1:1 of carbapenem to a carbapenem-sensitive Enterobacterias as a control patient. Descriptive data such as medians, proportions, and means, and also student t-test and managed with the test were used as appropriate. We used conditional logistic regression models to identify the risk factors independently associated to a carbapenem-resistant Enterobacterias. Our study is approved by King Abdullah International Medical Research Center, IRB. Regarding the result, the main result was the infection rate of carbapenem-resistant Enterobacterias in the patient admitted to the ICUs, which was 7.6%, and the incidence rate was 5.6 per 1,000 person day. Patients with a CRE were younger from the patient with a CSE, in a mean age 61 versus 64 respectively, but this wasn't statistically significant. Other patient characteristic was similar between the two groups. As we can see in figure 1.1, the SOFA and Neutric severity illnesses score were significantly higher in carbapenem-resistant group compared to the carbapenem-sensitive group. And regarding the other risk factors related to the carbapenem-resistant, all of the risk factors mentioned were significantly higher in carbapenem-resistant group compared to a carbapenem-sensitive, which includes the ICU length of stay, dialysis during the ICU, mechanical ventilation, previous surgery, and previous hospitalization 3 months before the positive culture. And regarding the mortality rates, it was 36.6 to carbapenem-resistant Enterobacterias, comparing to 19% to the carbapenem-sensitive Enterobacterias. And regarding the previous antimicrobial use, it was statistically significant for the carbapenem and aminoglycoside, whether other antibiotics such as quinolones, penicillin, cephalosporin. It wasn't statistically significant between the two groups. We did a multivariate logistic regression to analyze the significant risk factors between the two groups, and it has been linked to that carbapenem-resistant, aminoglycoside and carbapenem antibiotic use, mechanical ventilation, dialysis during the ICU, previous surgery, and length of ICU stay, Neutric and SOFA scores also, all were independently associated with the carbapenem-resistant Enterobacterias. Finally, our study concludes that the incidence of CRA infection was relatively elevated in a patient admitted to the ICU, and a patient with a high SOFA and Nutrix score, prolonged ICU length of stay, previous surgery, dialysis, and mechanical ventilation, and prior aminoglycoside and carbapenem use may have an increased risk of carbapenem-resistant enterobacteriase. Also, our present study provides an additional evidence that supports the importance of antimicrobial stewardship program to avoid the increasing incidence of carbapenem-resistant strains. And thank you. Hello.
شكرا جزيلا دكتورة هند. أنا ميبي دكتورة سجا لو يعني مرة أنا ومرة أنت تبدأي الكويستشنز ولا؟
السلام عليكم هند، الله يعطيك العافية.
وعليكم السلام، الله يعافيك، أهلا.
First of all, I was wondering what is the sample size of your study, because it is not clear to me.
Yeah, we screened 1,864 patients admitted to the ICU during 2018 at King Abdulaziz Medical City, and our sample size was 142 carbapenem resistant to 142 carbapenem sensitive enterobacterial patients.
Okay, lovely. Could you please explain the logistic regression section, please, because it wasn't clear to me. Why did you conduct a logistic regression, and you didn't address this as well in the abstract? So this is a very important part in your research, and I think it needs more emphasis.
Sorry, Dr. Saja, your voice is interrupted. Can you repeat the question?
Could you please discuss your logistic regression model?
Okay, when we got the risk factors for the carbapenem resistant, the factors that were significantly higher compared to the carbapenem sensitive, we applied the multivariate logistic regression to calculate the odds ratios and get the independent risk factors related to the carbapenem resistant.
Okay, what was your outcomes?
Outcomes of the study?
Yes.
To calculate and estimate the risk factors and the incidence and patient outcomes.
Okay, there is some contradiction in the statistical analysis. You said that you used t-test and Mann-Whitney, and these are both used in for continuous variables. So one of them is for if the data is parametric, and the other one is if the data is not non-parametric. Did you test the normality of the study? Why did you use both tests?
Because the chi-square is used for the categorical variables,
no,
and
chi-square. I asked about t-test and Mann-Whitney. T-test is used for parametric analysis, and Mann-Whitney used for the same to calculate the same or outcome, but for non-parametric. So I found this slightly contradicting.
Sorry, I can't recall.
Okay.
To apply the two tests at the same time.
Okay. Now, Dr. Mohammed, the mic is yours.
شكرا دكتورة ساجا. Thank you, Hind. Again, I have the same, maybe the same question that Dr. Saja asked. Can you elaborate more about one of your study aims is the patient outcomes? What was the result for the patient outcomes?
The results were to estimate the incidence and mortality rate, and also to determine the risk factors for the carbapenem resistance.
Risk factors is something else, but patient outcomes is this is the thing that I need to know actually more. Okay, thank you. I have no more questions.
Okay, thank you so much.
Thank you, Dr. Hand. Now we have Dr. Manal Al-Johani. She will present for us telepharmacy anticoagulation clinic during COVID-19 pandemic patient outcome. Dr. Manal, you can start sharing your slide and you can start.
السلام عليكم.
السلام.
صوتي واضح؟
Yeah, clear, واضح.
Can you see my slides, Doctor?
Yes.
Okay, let's start. Assalamu alaikum. Good morning. This is Manal Al-Johani, and today I will present our project Telepharmacy Anticoagulation Clinic during the COVID-19 pandemic patient's outcome. First of all, I'd like to start with a short brief introduction. The anticoagulation control for patient taking vitamin K antagonists, such as specifically as warfarin, has its major ongoing concern regarding the patient's safety due to warfarin's high-risk profile. As it is well-established, clinical pharmacist-managed anticoagulation services has achieved superior anticoagulation control. The telepharmacy anticoagulation clinics were established to ensure continuity of patients' care during the COVID-19 pandemic. This is a retrospective study that was conducted at King Abdulaziz Medical City at Riyadh during the COVID-19 pandemic with a follow-up of three months. Since the establishment of the virtual clinics during the COVID-19 2020, 270 patients were included in the study. Just to make it clearer, each clinic had an assigned coordinator that used to call the patients 24 hours to 72 hours before their scheduled virtual clinic with the clinical pharmacist, just to remind them to do their INR testing. Each patient had the choice to do their INR testing either at KMC's labs, King Abdulaziz Medical City, or outside it, and send the results for the to the coordinator via WhatsApp. Then, after that, the prescribed anticoagulation were processed by an ambulatory pharmacist to be sent to the patient with KMC's courier services. Our main aim of the study was to assess the telepharmacy clinic efficacy on warfarin doses adjustment and to evaluate patient safety with the virtual anticoagulation method for the first time in KSA. Additionally, the study has examined this model's effectiveness at the rate of bleeding and VTE episodes, as well as the cost effectiveness. Of the total of the 270 patients that were included, we had a mean age of around 59 years old. Females were dominant of the sample size of around 59%. And regarding to the comorbid condition, 49% of the patient had pre-existing hypertension, 42 had diabetes. For the indication of anticoagulation, most of our patients were anticoagulated for atrial fibrillation, reporting 45%, actually 46%, and followed by 20% for DVT and 14% for PE. The intended duration of therapy was for the vast majority for lifelong. And regarding to the duration of therapy upon recruitment, the vast majority of our patients, reporting 96, were treated for more than 6 weeks during the pandemic. Before the pandemic, however, we had 3% of patients who just started their anticoagulation treatment during the COVID-19 pandemic. Warfarin doses was prescribed in a weekly dose of 31.5 milligram. Surprisingly, even with the application of the curfew, 76% of the patients did their INR testing at KMC's labs. Around 91% of our patients were treated targeting a range of 2 to 3 for their INR. This table shows the anticoagulation control. We measured the INR values within the therapeutic range and the time of those INR values within therapeutic range. For the patient who just newly started on warfarin during the pandemic, treated up to 6 weeks or less, they reported 35%. of their INR values within therapeutic ranges and reporting 38% of the time within therapeutic range. For the for specific indication, atrial fibrillation reported the highest for time and values within therapeutic range, reporting 62. And regarding to the age groups, those who are aged 45 or less, they had the least control, reporting 56 for their INR values and 52 for their time in therapeutic range. Furthermore, classification of the percentage of the INR control. For overall, for the total 270, around 31% of the patients had good control, meaning that their time in therapeutic range was more than 70%, followed by 20 for those who had intermediate. Their time of therapeutic range was more than 50 and less than 70. And then lastly, majority of the patients, nearly half of the patients, the sample size had poor control. For each specific indication, 22% of patients who had VTE, VTE here, it includes the DVT and pulmonary embolism, so they had 22% of a good control. For atrial fibrillation, 35% of patients had good control, and for stroke, 45% of the patients had good control. The effectiveness of this method, of the virtual method, was assessed as the complication of therapy, reported as bleeding, whether it was major or minor, bruises. Minor bleeding was reported in 3% of the patients, and bruises was reported in 1% of the patients. The vast majority of the patients did not report any complications of therapy, reporting 95.5%. Lastly, the patients were administered the pharmacist satisfaction survey after being evaluated virtually by the clinical pharmacist to assess the patient satisfaction with this new method. The survey was consistent of 10 questions on a 5-point Likert scale from not at all to very much. The first 7 questions were consistent with the clinical pharmacist services satisfaction, and the last 3 were consistent with the satisfaction of the whole virtual new system. The overall median satisfaction for the whole 10 questions was 32, with an interquartile range of 28 to 36, of a maximum score of 40. The median pharmacist satisfaction score was 23 of 28, and lastly, for the teleconference satisfaction with the new method of the virtual clinics is 10 out of 12. To conclude and to summarize, this was the first study of its kind in Saudi Arabia during the COVID-19 pandemic. It was observed that this type of consultation was as effective as face consultation. Surprisingly, we did not encounter any significant bleeding or VTE rates during the whole study period and its follow-up. Most of our patients reported their satisfaction with this method. Savings in terms of money were not considerable. However, there can be a significant increase in resources and utilization with this new method. And thank you. You have any questions?
Thank you, Dr. Manal. Congratulations on your first. This is actually, yes, this is the first maybe telepharmacy study that is published. I have just only small questions. Did you compare the patient satisfaction with the face-to-face comparing to the telepharmacy as well? Or there is no any patient or any patient satisfaction face-to-face?
Patient satisfaction face-to-face, I cannot recall. However, we compared it to a study that was conducted at KMC by Dr. Al-Yusuf, but it was it measured the time therapeutic range and the anticoagulation control in patients. However, it was physical clinics.
Okay, great. If you feel, my second question, if you feel that majority of your patients that they were asked to do the INR test and they did it in KMC, Is it worth to do it in a telepharmacy? Or since the patient is already in the hospital, you can ask him just after going to the lab and you make the lab test, you can go to the clinic immediately.
This approach was taken to ensure social distancing and to just minimize the contact.
Or
and
do
the
you
viral.
really we have to use the telepharmacy for all patients?
Yes, because most of the patients during doing the survey, they actually liked this method. It was much easier. They used to come early morning just to do the labs and the KMC, and they'd leave, waiting for the clinical pharmacist call. So it was much more convenient for the patients from the patient side.
Those for the patients living in Riyadh. Yes.
In Riyadh and out of Riyadh, even out of Riyadh. And there was
So
a
the patient
significant.
out of Riyadh, they like to come to just only to make the lab test and then go back to their region?
We had some, yes,
waiting
we had some
for the pharmacy?
We had some patient who just came for doing the labs and left because their main concern was that the INR testing was expensive outside in private hospitals. So this is the reason that they used to come to Riyadh.
Okay, thank you.
Welcome.
دكتورة سجا.
الله يعطيك العافية منال.
فيك دكتورة.
Could you go back to your slides, because I couldn't remember a methodology slide. Did you present your methodology?
The methodology?
I don't
yes,
remember.
it was in the introduction slide. Just a second, I will open it.
Because I don't remember any slides for methodology. That's why I was quite surprised.
It's for a while, please. Can you see my slides?
Yes.
Okay. It's here. Retrospective study with 3 months.
Okay, this is a very. Do you think this is a very short methodology?
Yeah, I know. It is very short, but I was limited with the number of slides and the poster.
Yeah, because actually you presented a lot of tables. You could summarize your tables in 2 or 3 slides and at least explain the methodology a bit further. I have one question regarding the resources. You said that the resources was not, in the last slide, you said the resources was not considerable, and you think that this telepharmacy will cost more, right?
There is we can utilize the resources more in telepharmacy.
Or you mean that it is more costly, or it is not
less costly?
Yeah, you said here, nevertheless, there can be a significant increase in resource utilization.
Yes.
So it is more costly.
We meant by this because there was around 70% reduction in the cost of the coagulate checks for the point of care testing, okay, and for the clinics and the nurses services, as well as the time spent for each patient during the consultation with the clinical pharmacist was less during the virtual clinics. Usually each patient had 10 to 15 minutes on physical clinics. However, in the virtual clinics, the time reduced to 5 to 10. So more patients can be seen during each day of clinic.
So it is more expensive. The conclusion, it is more expensive. Do you think it is more expensive, right?
It is more cost saving, but we meant here by cost saving and utilization sources saving, not cost.
Because resources means cost.
We meant okay. I think we meant by this resources that the clinical pharmacists can have more time to see patients. The nurses can have more time to do other things like saving and nursing services, and the coagulate checks were much less on behalf of KMC.
Okay, because the last sentence was quite contradicting, because saving in terms of money were not considerable, and then it said, nevertheless, there can be an increase in resource utilization. So in economics, even the nurse's time and the pharmacist's time, it is a resource by itself. That's why I was quite confused with this sentence. You don't have any comparison, so I was just remembering Dr. Shinawi question. Did you have any comparisons in terms of outcomes between tele and face-to-face clinics?
Yes, we had comparisons in the time therapeutic range and the anticoagulation control. However, in money savings, in terms of money savings, actually, we did not find any.
Now, I suggest you look into this more in more depth in the future, because this is a very interesting study, and I think this model of care can be implemented widely even after the COVID-19. So I suggest you will look into the resources utilization and calculating the costs. Thank you so much.
Thank you.
Thank you, Dr. Manal. Thank you for our judge, Dr. Shinawi, Dr. Saja. Now, Dr. Hadil Al-Ghaidi and Dr. Mohammed Harvey, they will join us as a judge for the coming topics. Dr. Uhud Al-Shehri also should present for us how COVID-19 affect the patient, effect on the patient with chronic disease. Dr. Uhud, you can start sharing your slide. Dr. Ahud, are you with us?
Yes, can you stop share for your slide? You want to do?
Okay, now you can try. Just I want to confirm, Dr. Hadil and Dr. Mohammed, are you with us?
Yes, I'm here.
I am here.
Okay, thank you.
Okay, right now you can see my slide.
Yes, we can see it. Can you put it in the full screen, please?
Okay. So sorry, Assalamu alaikum. I am Ahud Al-Shehri, pharmacy student at King Khalid University.
Dr. Ahud, sorry, but we cannot see your slide in the full screen.
Now?
No, we cannot see it.
Okay, can you show? Yes, doctor.
Okay, we will share it from our side.
Okay.
Okay, this is your slide. You can see it now?
Yes. Okay.
Okay, just inform us whenever you want to advance the slide and allow for around 3 seconds for lag time. You can start now.
Okay, I am Ahud Al-Shehri, pharmacy student at King Khalid University. Today I will be present the result of our research was the title How COVID-19 Affect on the Patient with the Chronic Disease. Introduction. During the first month of 2020 due to the coronavirus disease, COVID-19, The pandemic government in the many countries initiated containment measures with different approach ranging from restriction population movement and increased social distancing. The healthcare system began postponing and avoid unnecessary hospital visitors. The significant decreased routine care, especially with the diabetes and chronic obstructive pulmonary disease and the hypertension. Movement, doctor. During these factors, the physiological impact of this pandemic may decrease adherence and possible corroding health gain made barrier to the pandemic in the patient with a chronic disease. We aim to assess the physiological impact during the epidemic of the COVID-19 on medication adherence with a chronic disease. In the method we use for the study design, we use a cross-section was carried out to assess the direct physiological impact of the public during the COVID-19 pandemic on medication adherence by using online questionnaires and Twitters and email. The participants in this survey were adults with a chronic disease, and the most frequently chronic disease in our population was diabetes, and the medication are initial for your health and take the medication regular. This research was reviewed and approved by the Officer of Research Adherence at King Khalid University. The structured questionnaires consist of the question that cover several areas. So the data collected including 1, the demographic data, 2, the impact of the COVID on daily life and disease severity, 3, the physiological impact of the COVID-19 outbreak and the mental health state, 4, the impact of the COVID-19 on medication adherence. The statistical analysis, we use the percentage of response will be calculated according to the number of response will respected to the number of the total response of the question, and we use the linear regression to calculation universal association between demographic characteristics, lifestyles and severity of disease, and the impact of the COVID-19 outbreak of the physiological and the mental health state and the medication adherence. All tests were check-square with the significant level of the p-value less than 0.05. Statistical analysis was preferred by using SPSS statistic. In the result, this study conducted 274 questionnaires and reserve survey. 78.55% were female and 21.45% is a male. And the high frequently chronic disease in our population was diabetes with 10.6%, followed then hypertension with 7.3%, and the immune disease with 4.7%, and equal proportion of the heart failure and the kidney failure. The mean age was 35 years with the percentage 37.4, and here the main range of the age with between the 18 to the 65 years, and the majority of response is Lebanon Asir with 6.2%, then in Riyadh 22%, and Jeddah 11%, and Mecca 4.4%. Moreover, the high percentage first slide, doctor. Moreover, the high percentage of participants with the college with the 75.8% and the high school 15.9%. Over half of the survey reported in our study with 12.3% is of the patient not to go to the hospital, visit to the hospital, and 16.7% of the patients go 1 to 2 days to visit the hospital, and 3.1% of the patient will not go more than 3 days per week to the hospital. Only a minority of response was 19.8% of the patients through the COVID-19 had overt impact on the severity of illness and or daily life. Well, COVID-19 had 28.2% is a mild and 37% is a moderate, and 15% is a severity. Is a severity, and no, doctor, before. concern we expected about the patient to go to the hospital. So the majority of the patient going alone with the 52.9%, and with a family member with the 47.1%. Second, doctor. Okay, in this slide, I will be describe some question at present in the survey, but is not all questions and not all answer because the limited number of the slide and the time. So the first question: do you always remember to take all your medication according to your doctor's instruction? The most frequently answer is always with the 63%. And I have another answer, like sometimes with the 34%. Second question: do you happen to change the dosing of your medication without barrier of counseling with your doctors? The most frequently answer is never, with the 79.3%. Second, doctor slide. According in this slide, the physiological impact of the data show the significant value in the marital status, and here we see the correlation between demographic factors and the physiological impact. Second, there was a significant positive correlation during the COVID-19 pandemic in the mainstream of the patient find all medication are necessary for your health and take medication regular, and the patient is not change the dosing of the medication without counseling in the doctors. So here the correlation between demographic factors and the medication adherence, the significant in the disease. The last slide. In the last things, this study highlighted medication adherence, and the results of the survey show that with the chronic disease, however, the significant impact of the influence in the daily life on medication adherence. And thank you.
Thank you, Dr. Hamid. Would you like me to start? Thank you for your presentation. I have a few questions. How did you measure adherence? Was this tool a validated tool for adherence that you used? From where did you get the questions on the survey? The survey questions that you had, from where did you get them?
From the all question?
Yeah, the all and specifically the adherence.
For the patient, for all survey, for all questions in the physiological, you have a question for the physiological impact and some in the medication.
But I mean, what was the source of the questions? Did you get it from a previous validated survey? Did you come up with the questions from different papers? Right?
Some question have a previous and some question is not.
Okay. It's preferable to use a validated tool to measure exactly, because just having questions, I'm not sure if they're validated, if they measure what you want them to measure, could be a limitation in your research. Another thing I have, I think your title could be a little bit different, because not all patients in your study had chronic diseases. You said mainly patients, but not all of them. And in the title, it says how COVID-19, let me read it again, the title. Okay. How COVID-19 affects patients with chronic disease, but not everyone had chronic disease. So I wouldn't put that in the title. I would say how affects subject in general, but not specific, or you exclude patients without chronic diseases. That's my suggestion.
Yes, here in the title, how the COVID-19 affect on the patient with a chronic disease. But in our research, the positive answer, the COVID-19 for the patient who have COVID-19, it will be affected in the medication. And we have the patient with not COVID-19 with not affected in the medication adherence.
Okay, thank you.
يعطيك العافية عهود. I agree with Dr. Hadil regarding the validated questions, because it has to be validated before you send it to the patients. So you said you use Twitter and use internet questionnaire. How you could possibly know that actually the patient themselves whom filled these forms, or maybe their relative or some actually wants to help you with the questionnaires?
Okay, I sent it for the many times, and some of family members you have a COVID-19, and some if you have a coronavirus, so it will be answered these some questions. And I'm sure for not all, but I'm sure some questions will be answered good for this patient with the chronic disease.
طيب يعطيك العافية، شكرا لك. No more questions.
Thank you, Dr. Ahod. We have modification in our program. Nora Bnaya, she will not present right now, she will present later. We have Nora Shrem, she will present for us impact of fasting Ramadan on admission to the hospital with a diagnosis of acute kidney injury. Nora Shrem, you can share your slide and you can start.
Assalamu alaikum. Did you see my slide?
We can see it. Can you put it in the full screen, please?
I'll try now again. Is it now fine?
Yes.
Is it fine? Okay.
Yeah, good. Thank you.
Thank you for all organizers and judges. I'm Noura Shrem, pharmacy resident R1, King Abdulaziz Medical City, Riyadh. I will present my research, which is impact of fasting Ramadan on admission to hospital with diagnosis of acute kidney injury. This research done by my colleague and I, and the primary author of this research is Dr. Na'man Al-Abdan. For introduction of this study, we all know the Ramadan month. We are, as a Muslim, we have abstained from food and drink for, in our region, approximately 15 hours, and most of the years it's during summer season. That could lead to dehydration in some population, and dehydration also a well-known risk factor for acute kidney injury. So in this study, we would like to assess the relation between fasting and risk of acute kidney injury to identify the patients who are at high risk of acute kidney injury. For this purpose, we choose the method, which is case control study, and we include all the patients who were admitted in our hospital from ER during Ramadan and month after or before to have a control cohort. We include all the patients and we exclude only the patients who are cancer patients on active treatment or the patients who are lacking of baseline of serum creatinine, so we cannot convert if the patient acute kidney injury or not. And we exclude also the elective admission. Also, we choose for statistical the chi-square for nominal data and multiple regression or logic regression analysis to examine the correlation between fasting Ramadan and the risk factors. This is a study where approved from King Abdullah International Medical Research Center. And as a result, we end up with 1,199 patients included, but the baseline characteristic was to differ between two groups. So we did a match control group, and we end up with 998 patients with no statistical difference in the baseline clinical parameters. However, we still have a statistical difference in the prescribing medication with the patient taking before admission. The incidence of acute, as a result, or the result of the primary objective of this study was statistically significant lower in the fasting cohort, thus that were a lowering of the risk of developing acute kidney injury in the fasting patients with adjusted odd ratio 0.61. Also, we did analysis for other risk factors that could contributed to lead acute kidney injury, and we found some statistical significance in the patient with a Charlson comorbidities index more than 4. Also, the patient who had a history of acute kidney injury more likely to have another acute kidney injury during Ramadan. We have also statistically significant lower risk of OD of acute kidney injury in the patient who had serum creatinine less than 60. Interestingly, for the medication that's well known that could contribute or cause acute kidney injury, there were no statistical significance in this study. So there is no specific medication could increase the risk of acute kidney injury in this population. So as a discussion, the result was contrast to what we expecting to see. The results show the fasting was fact associated with the less hospital admission for acute kidney injury. This study also investigated the risk factor of acute kidney injury to identify the risk of patients. However, the finding is similar to other studies that assess of acute kidney injury, that finding there is no correlation between any medication used to develop acute kidney injury. As I said before, it's interestingly that the patient during Ramadan is less likely to use a nephrotoxic medication. As a conclusion, the result of the study is reduction in the incidence of acute kidney injury in the fasting patients, and the data shows strongly reduction of the risk of developing acute kidney injury as a benefit of fasting. Therefore, the most patients with comorbid disease would not harm from fasting Ramadan. However, to have a better understanding, a large prospective study are needed to investigate the benefit of fasting in reducing the risk of developing acute kidney injury are needed to confirm the finding of this study. And thank you. Are you hearing me? Hello?
Yes, we hear you. Yes, we hear you.
Thank you, Noura, for your presentation. I have a question here. You said surprisingly patients were less likely to use nephrotoxic medications in Ramadan. Why do you think this is surprising? To me, actually, it's not surprising. I would think this is the norm, is to use less medication. Even their own medication would be less. So using some other extra medications would be less in Ramadan. They would less likely to see doctors, less likely to introduce new medications. So why did you think this was a surprising finding, that patients would use less likely nephrotoxic medications in Ramadan period?
Actually, the surprising part is not using less medication as much as it doesn't increase the risk of having acute kidney injury. What we expected from this study that the patient could have risk or there is any medication could increase the risk. The surprising that there is no statistical significance at all.
Okay, thank you for your answer. And I have another question. How many patients were in the control? I just didn't see that. Can you? So there was 900 something patients cases. You mean cases on control, or there was a different set of controls?
No, this is the total. 999 is the total.
Okay.
Yes.
So you had some of them were cases, some of them were controls. And the controls, how did you get the controls?
No, actually it's 499 for each group, that's mean.
Okay. How did you get the control subjects?
The control subject, the month following the Ramadan.
So it was the same subject in a different month or a different subject and not in Ramadan?
Different subject in that different month. It's following Ramadan.
Okay. Okay, thank you for your answer.
يعطيك العافية دكتورة نورة. What was the reason or the cause of admission or the cause of acute kidney injury in those patients? يعني regardless إنه رمضان what was the actual cause for acute kidney injury?
We expect that kind of acute kidney injury in those patients is community-acquired acute kidney injury, as they are from ER.
So there is no actual investigation or cofactors that lead to acute kidney injury, regardless if they are fasting or no?
You mean that patients had acute kidney injury if it is related to fasting or not? Actually, there is a lot of compounding factor in this, and we did not study. We study only the risk factor that we are looking for, like comorbidities, hypertension, diabetes, all these comorbidities we studied, but we did not identify each patient why he had acute kidney injury.
Do you think there is a risk of bias in these things, that you don't address the other factors that might lead to acute kidney injury in these patients?
Actually, this is the purpose of the study, to find the risk factor, but for sure, as it is a retrospective study, for sure there is a risk of bias. But we tried as much to find any risk that could lead to acute kidney injury, and we listed, and the list that I showed you, it's not the full list of the comorbidities. We do more, but this is an example, and I mentioned the most significant things. We try to find the comorbidities or the risk that lead to acute kidney injury, but this is what we have as a result, as a final result.
Right. Other questions for the medication used during Ramadan. You mentioned those admitted patients in hospital. So
yes.
The medication was controlled because they are fasting, or because they don't want to take these medications. You said there is less NSAID, there is less PPIs. Do you relate that during the because of the long fasting hours that we have? We fast for 14 hours or 15 hours. Maybe the amount of medication will be less. Did you put this into account?
Actually, the history of the medication that we take it from the best care from the system. We did not interview the patient and ask them, did you see it or not? This is the result of the data that we retrieved from our system. So it's not specific or a different report for medication that patient used.
Yeah, but you didn't review the nursing note when you're reviewing the medication orders?
This is what we do. The medication that you see it now, we take it from the system directly. But I mean, we did not ask the patient at home, did you continue this medication or not?
No, you didn't understand me. Actually, the nursing notes, because they are admitted patients. So each nurse will document that the patient received this, the patient refused this, the patient is fasting. So you didn't screen the nursing notes for these reasons?
Because, doctor, our point from that we take the patient who came at the ER. So we assess the patient who came with ER. So we would like to see the medication that the patient were on it, not the patient who use the medication right now. This is the point. This is why we check the previous medication that patients were on it before.
Okay. يعطيك العافية. شكرا جزيلا.
I hope that I understand your question.
No, it's okay. يعطيك العافية.
Dr. Hadid, Dr. Mohammed, you have any further question or comment?
No further question. Thank you.
Okay.
No further question.
Okay, thank you. Thank you, Dr. Anora. Now we have Dr. Msha'al Al-Mtairi. She will present for us the appropriateness of using vitamin K for coagulopathy secondary to hepatic disease in critically ill patient, a retrospective cohort study. Dr. Msha'al, you can share your slide now.
Good morning, everyone. It's a slide appear for you.
We lost it. We just have it, and now it's gone.
Wait, doctor.
Yeah. Can you do full screen?
Yes.
Okay.
Okay.
Good. Yeah, you can start.
Okay. Good morning, everyone. My name is Masha Al-Mtairi. I'm pharmacist at King Abdulaziz Medical City National Guard Hospital. Today, I will present for you one of my research about appropriateness of using vitamin K for coagulopathy secondary to hepatic disease in a critically ill patient. We'll give you a brief introduction. The many patients with chronic hepatic disease have coagulopathy secondary to failure in synthesis of both antithrombotic and thrombotic factor. Patients with chronic liver disease at increased risk of both thrombosis and bleeding, and the risk is varied depend on liver disease severity. Like patient in end-stage liver disease, cirrhosis, have imbalanced coagulation profile, and are the risk of both excessive clotting and bleeding is high. Talk about vitamin K. Vitamin K is fat-soluble vitamin and usually administered in dose range between 1 to 25 milligram per day through oral or intravenous route of administration, depending on severity and cause of vitamin K deficiency. And vitamin K plays an important role to synthesize active form of coagulation and anticoagulation factor, which include. Hello, Doctor.
We lost the slide.
Right. Now, Doctor?
Yes, you can share.
Okay.
Okay, good. Thank you.
Okay, we stop in vitamin K. Vitamin K plays an important role in synthesize active form of coagulation and anticoagulation factor, which include prothrombin and many factors in coagulation cascade. Using vitamin K or patient with liver disease and abnormal coagulation often receive vitamin K, despite a lack of evidence supporting the beneficiary. And supplement vitamin K may correct abnormal coagulation in patients with high risk deficiency due to many disorder or prolonged antibiotic use, and also and use it as antagonized warfarin in patients using warfarin. However, using vitamin K for coagulopathy correction secondary to liver disease without any risk is controversial and with limited evidence. The aim of our study is evaluate the using of vitamin K in a critically ill patient with INR elevation secondary to liver disease. We have secondary primary outcome and secondary outcome. When we talk about primary outcome, we evaluate the efficacy and safety of vitamin K. The efficacy include the INR degree of INR correction, incidence of bleeding, and RBC platelet transfusion requirements. And the safety outcome include incidence of all thrombosis cases and hospital-acquired infection. Secondary outcome were ICU mortality, mechanical ventilation duration, and ICU hospital length of stay within 6 months. This is a retrospective cohort study of adult ICU patients who have coagulopathy secondary to liver disease in the ICU at King Abdulaziz Medical City from 1 of January 2018 to last of December 2018. We enrolled a total of 1,864 patients were reviewed to screen patients for inclusion into the study. Only 98 patients meeting inclusion criteria were enrolled. Patients were dividing into two groups based on using vitamin K, to vitamin K group and non-vitamin K group. Also, the study was approved in August 2019 by King Abdullah International Medical Research Center in Riyadh, Saudi Arabia. When we talk about inclusion and exclusion criteria, we only include the critically ill patient aged and above than 18 years old with hepatic disease and confirmed coagulopathy. We confirmed coagulopathy as INR more than 1.5 within 24 hours of ICU admission. As we said, the patient with the prolonged antibacterial therapy for more than 21 days may be altered hemostasis. So we exclude from our study also the patient receiving a vitamin K antagonist, direct inhibitor of factor 10 or thrombin inhibitor, and any patient with risk of thrombosis or bleeding. Like many comorbidity that causes coagulopathy other than hepatic, like systemic lupus erythematosus, anticoagulant hypothrombocytopenia syndrome, and many diseases that increase risk of bleeding and thrombosis, like hemophilia B and hemophilia A, and protein C and protein S deficiency syndrome. Also, we exclude the patient if they have ICU length of stay less than 1 day. Collected data was entered in Microsoft Excel after being coded. There were two arms, as we said, considered in this study: patient who received the vitamin K and patient who didn't receive the vitamin K. As expected in observational study, differences in baseline characteristic between the two treatment groups maybe exist. To adjust for these differences, the propensity score for use of vitamin K was generated with Apache and SOFA score. We consider a p-value less than 0.05 statistically significant, and the odd ratio and estimate with the 95% confidence interval were reported for the association. Let's move to the results of our study. The study included 98 patients. Out of 48% only had received vitamin K during the study period. This table shows the baseline characteristic of vitamin K and non-vitamin K group, like age, body mass index, weight, hypertension, chronic obstructive pulmonary disease, diabetes mellitus, and many different characteristics that may be alternate to bleeding or thrombosis risk, like bilirubin and D-dimer and platelets and ABTT. All these characteristics is insignificant when adjusted p-value. This table shows the safety of the vitamin K, some safety parameter, and when we see the venous thromboembolism, see the rate of venous thromboembolism were 17.02% in vitamin K group as compared of 3.92% in non-vitamin K group. Patients who received the vitamin K group were 2.4 times more likely to get venous thromboembolism as compared in the patient with non-vitamin K group. However, this association was not statistically significant when adjusted for propensity score. All bleeding risk is not significant also, and we see the infection, we see the pneumonia more than 7.4 in vitamin K group compared with non-vitamin K group, and this difference is significant. This table also show us the safety of vitamin K group. When we see the RBC transfusion and platelet transfusion and fresh frozen plasma, this is all insignificant between two groups. But ICU length of stay and mechanical ventilation duration is statistically significant by 0.03 and 0.01 respectively. This table show us the using vitamin K for correctional coagulopathy to liver disease observed only on first dose was statistically significant. This table shows the efficacy of vitamin K in chronic liver disease patients. But other subsequent doses of vitamin K were not statistically significant for correction. The change were calculated as a difference between pre and post dose, and also most of the patient received IV route of administration of vitamin K. This table shows association baseline severity between vitamin K and non-vitamin K group. The baseline batch score and SOFA score and Nutric score were not statistically significant between the two groups. This table shows the bleeding cases as well as the thrombosis cases among the different child score. This score shows us the severity of liver disease illness. And we see patients with child C score have a higher rate of all thrombosis cases by 8.33, as well as bleeding cases are 9.38 compared to child B and child A respectively. We conclude our study. First of all, vitamin K was efficient in reducing INR level for critically ill patients with coagulopathy secondary to liver disease at the first dose only. Other subsequent doses were not. Patients who receiving vitamin K were more likely to have longer ICU length of stay, mechanical ventilation duration, and higher rate pneumonia within ICU state compared with patients who didn't receive it. The routine prescription of vitamin K in a critically ill patient with coagulopathy secondary to liver disease warrant further evaluation. We have potential limitation in our study. The heterogeneity of ICU cases, medical or surgical, and the liver disease severity like acute on top of a chronic were not determined in our study. Also, they are subject confounding that may influence our model finding. Also, we need a more well-designed study, like randomized control study with large sample size to confirm our finding and to confirm the appropriateness of using the vitamin K in critically ill patients with liver disease. Last, thank you for your attendance, and special thanks for Dr. Khalid Suleiman for all your support. And I'm welcoming for any question. Thank you.
يعطيك العافية دكتور مشاعل. I have a question. Did the vitamin K group were sicker than the non-vitamin K group in the ICU, or it wasn't actually measured?
Thank you for the question, Doctor. Actually, vitamin K, when collect the data of best care, we see we separate the vitamin K and the patient received the vitamin K and the patient not receiving the vitamin K for every single patient.
No, I didn't understand my question. Did the group of the patients who were receiving the vitamin K were actually sicker, because the outcome was better with those who didn't take vitamin K? So did you take into consideration there might be sicker patients, so the subsequent doses of vitamin K will not be beneficial in them?
No, doctor, actually no. I didn't understand your question. What does that sticker mean?
طيب, I mean that you have two groups. عندك two groups.
Yes.
الجروب اللي ياخذ الفيتامين K والجروب اللي ما أخذ الفيتامين K. Both of them they have chronic liver disease.
Yes.
طيب, مين كان much sicker patients؟ مين اللي كانوا هم اللي الكيسز حقتهم were severe؟ هل هم كانوا اللي في الفيتامين K جروب ولا اللي كانوا في النون فيتامين K جروب؟
in our finding يعني different, the baseline is different between vitamin K and non-vitamin K group. يعني ما في كرايتيريا معينة بتحدد لنا مين السكر، يعني مين اللي كانوا مور سكر، الفيتامين K or non-vitamin K group.
Okay, طيب. يعطيك العافية. I don't have further question.
شكرا لك مشاعل for your presentation. I have a question. Can you show me the propensity score you had? You did a lot of adjustments using propensity score and other multivariate analyses. How many patients did you have in total?
In total, 98.
Yes.
98 patients.
So I really truly appreciate doing this a lot of analyses, but with 98 patients, you're probably over adjusting, coming up with p-values that are maybe not correct. So just to let you know, 98 patients is a very small number to do propensity score adjustment and to adjust for multiple variables. You can do propensity score, but propensity score with other variables like plus multivariate model, I think it's a bit difficult with that number of patients that you have, the 98 patients. So I'm not sure. I think maybe you just need to revise the number of variables you have in your multivariate models, or you can present them in just univariate analysis rather than having multiple adjustment models, and maybe do correction for multiple testing rather than multivariate analysis. That was my only concern. Like, do you know what's the limit? How many variables you can have in your model per outcome?
Yes, doctor. One of our limitation in our study is sample size. I think many variable it's significant before adjustment, but after adjustment it's non-significant. So we need more study with large sample size to confirm our significance.
Okay, and did you do the propensity score adjustment? What does that mean? Because I saw one of the table did propensity score. Can you explain to us what this propensity score means?
Yes, doctor. The baseline characteristic is difference between the two groups, but when adjusted propensity score, it's a statistical analysis, by the way. This is did in the statistician, but as we know in the observational study, there is a multivariant characteristic. It's variable between two groups, and we adjusted in this study to with Apache and SOFA-score.
Okay, thank you. Thank you for your answer. I have no further questions from my side.
Thank you, Dr. Musha'ad. Now we have Nada Saleh. She will present for us exploring physician view, perception and experience about broad spectrum antibiotic prescription in tertiary care hospital qualitative approach. Dr. Nada, you can share your slide now.
Assalamu alaikum. Can you hear me?
Yes, we can.
Hi. Can you share the slide for me, please?
Okay. Share on both sides. Can you see it now?
Yeah, thank you.
Okay, just tell us when do you want us to advance the slide and allow just for 1 or 2 seconds for lag time.
Sure.
You can
Thank
start.
you. Good morning, everyone. I'm Nada Saleh, a PhD student at Statistical University. I will be presenting our qualitative study exploring physicians' views, perceptions, and experiences about broad-spectrum antimicrobial prescribing in a tertiary care hospital. Could you move to the next slide, please? Inappropriate prescribing of broad-spectrum antimicrobials in hospital settings is one of the contributors to the emergence and spread of the antimicrobial resistance. Antimicrobial prescribing is a multifaceted decision-making process that can be influenced by both clinical and non-clinical factors. In order to implement or develop an intervention that aims to improve or optimize the antibiotic prescribing practices, it's important to understand these factors. The aim of this study is to explore physician views, perceptions, and experience regarding the broad-spectrum antimicrobial prescribing in a hospital setting. So this was a qualitative, semi-structured telephone interviews. Participants were from hospital physicians who prescribed broad-spectrum antimicrobials for the adult hospitalized patients. In this study, the route of sampling was adapted as the sampling strategies, where the physicians were recruited based on their experience on broad-spectrum antimicrobial prescribing for the adult hospitalized patients. In addition, snowball sampling strategy were used, where the interviewed physician were asked if they have colleagues or peers who interested in who prescribe broad-spectrum antimicrobial prescribing and interested to participate in the study. It was conducted in a tertiary care hospital in Riyadh. The interviews were conducted during 3 months, from April to June. Participation in the study was voluntary, and all physicians were reviewed and signed the electronic consent form before the start of the study. Interviews were transcribed, imported into the in vivo software, and analyzed thematically follow the random flags approach. Next slide, please. Data saturation was achieved by 16 interviews. 4 major themes and 19 sub-themes were identified. These themes were the views on broad-spectrum antimicrobial prescribing, factors influencing broad-spectrum antimicrobial prescribing, barriers to antimicrobial stewardship, and recommendation to remove the appropriate prescribing of broad-spectrum antimicrobials. So under the first theme, which was the views on broad-spectrum antimicrobial prescribing, it was found that physicians' sense of inappropriate prescribing was determined more by missing or not covering a suspected infection than by avoiding negative consequences associated with the over-coverage prescribing. It was found also that physicians recognize that broad-spectrum antimicrobials are overprescribed. Under the second theme, which was the factors influencing broad-spectrum antimicrobial prescribing, several factors were identified, either patient-related factors or physician-related factors or other external factors. So under the patient-related factors, it was found that patients with comorbidities or severe clinical presentation were tend to be prescribed broad-spectrum antimicrobials even if not needed. The physician expressed the fear and anxiety about missing infection for those patients. Under the physician-related factor, it was found the physician habit of prescribing broad-spectrum antimicrobials even if not indicated, and the decision-making anatomy were a factor that influenced their prescribing. Diagnostic uncertainty, where in some situations the inability to differentiate between some kind of bacterial infection sent the physician to prescribe broad-spectrum antimicrobials to be on the safe side. And also, impact of senior physician was also reported. Why, when we interviewed the junior physician, they described like having a pressure from the senior to prescribe broad-spectrum antimicrobials even if they don't want to prescribe. Under the barriers to antimicrobial stewardship practices, several barriers were identified. Of these barriers, there was lack of knowledge and awareness about the importance of the antimicrobial stewardship practices. And also, there was lack of communication and coordination between different multidisciplinary teams. And also, there was what an organizational constraint where the physician reported having no remote access to the patient profile, lead them to prescribe broad-spectrum antimicrobials, delay in getting some culture results, lead them to not de-escalate the broad-spectrum antimicrobials. When we ask the physician to provide their recommendation to improve the appropriate broad-spectrum antimicrobial prescribing, several suggestions were made by the physicians. Of this, they highlight the need for having like educational and awareness about prescribing broad-spectrum antimicrobial prescribing. Also, they report they want to have like audit and feedback. They want to know about their prescribing practices, and also they suggest they suggest to improve the logistic of cares. So to have like a faster culture results, to have a remote access to the system. The study identified several factors that could influence the broad-spectrum antimicrobial prescribing decisions. These factors can help to guide the design of a multifaceted intervention to support the physician and policymakers to improve antimicrobial prescribing practices and to improve the antimicrobial prescribing practice and to decrease the antimicrobial resistance. At this point, I'm ready for a question.
Thank you so much, Nada, for this nice qualitative research. It was nice presenting it. Can I ask you, what's the next step for you for this project? Like, what would, I'm assuming this is part of maybe several projects. What would be next? What would you think, what you can take from this, and how can you improve clinical practice out of what you got from your study?
Mm-hmm. Thank you for your question. Actually, this is it's a part of a larger project. So the first part was like a quantitative drug utilization study, and we audited the prescribing. The second, so we found a lot of like inappropriate prescribing practices. So then we conducted the second study. So we want to see we want to study the behavior of the physicians, and so we can implement an intervention that is direct, I mean, to their needs. So the third part will be like implementing an intervention to improve the prescribing practices.
Okay, and this intervention will be adapted from the themes you received, from the issues you received from the prescribers.
Yeah, it will be actually implemented from both, I mean, from the first and the second study.
Okay, thank you for your answer.
يعطيك العافية دكتورة ندى. I have first 16 physicians that you interviewed. It's not a small number that to put a conclusion on.
Actually, in qualitative study, so we didn't calculate the sample size. So it's usually saturation. So every interview we review what we have, what the new ideas. So if there is no new ideas emerge, so we will stop interviewing more, physicians.
طيب, did it's actually about the broad spectrum antibiotic perception, but did the level of the physician differs or the speciality of the physician differs in their responses? So did you interview different specialities, or you didn't because you didn't specify actually in the research whom they were junior, how many years of experience they would have, and the different specialities that they have, because there's a lot of specialities that they overprescribe antibiotics, and there are some specialities they don't actually encounter with antibiotics too much.
Mm-hmm. Actually, we have interviewed physicians from different specialties: internal medicine, infectious disease, orthopedics, neuro, and surgery. And I also have different levels, starting from resident, junior resident till the consultant.
Okay. يعطيك العافية. شكرا لك. I have no further.
Thank you, Dr. Nada. Now we have Dr. Nora Spey. She will present for us the prevalence and risk factor of 30 days readmission after acute myocardial infarction in large tertiary hospital in Saudi Arabia. Dr. Nada, you can now share your slide and you can start. Sorry, Dr. Nora. Can you put full screen, please? Okay, we can see your slide. You can start. So Nora, we cannot hear you. Dr. Nora? I think there's a technical issue with the mic, Dr. Nora. We'll wait a few minutes. Inshallah, will be fixed. Still have time. We have the slide now. We will fix the. Dr. Nora, we will put you on the speaker by the phone, so you can present by your phone, mobile, and you can control the slide from your computer.
Okay, you hear me now?
Yeah. The judge, do you hear Dr. Nora?
Talk louder, please, Dr. Nora.
Okay, just try to speak louder. You can start now.
Several countries, and the 30-day readmission rate after hospitalization is high and associated with increased risk of poor prognosis. The aim of this study is to evaluate the prevalence and risk factors of 30-day readmission after acute myocardial infarction in a tertiary hospital. A retrospective study was conducted at King Abdulaziz Medical City in Riyadh. Patients who were admitted with the ACS between January 2016 and December 2017 were included. Readmission was defined as the first admission within 30 days following the patient discharge for the index hospitalization. Baseline characteristics, complications during the first admission, and the use of guideline-directed medical therapy were examined for cases that were associated with readmission and compared to cases that were not associated with readmission using chi-square test for categorical and t-test for continuous variable to identify the patients that were at high risk of readmission. The study was approved by the IRB Abdullah International Medical Research Center. In terms of results, our study included 475 patients. 14.9% of them were readmitted. The mean age of the patients is 60. The number of male patients were 375, which represent 78% of the sample. 54 of them were readmitted to the hospital. Female patients represent 21% of the sample. 23 of them were readmitted. In terms of the diagnosis at admission, as you can see here, 53.1% of the patients were diagnosed at admission with non-ST segment elevation myocardial infarction, and 56.3% of them were readmitted. Most of our patients went for PCI. Regarding to the comorbidity, 234 patients had coronary artery disease, in which 20% of them were readmitted with p-value less than 5%. 19 patients had anemia during the first admission, and 31% of them were readmitted. As you can see in the second table, regarding the use of guideline-directed medical therapy, 85% of the non-readmitted patients received beta blocker, while only about 14% of the readmitted patients received them. For angiotensin-converting enzyme ACE inhibitors, 322 of the non-readmitted patients, which represent which represent 87% of our patients received ACE inhibitors compared to the only 13% of the readmitted patients. And this difference is statistically significant. The p-value equal 0.021. The use of all the other guideline-directed medical therapy was lower among the readmitted patients. However, there were no significant differences between the two groups. In terms of complication, most of the readmitted patients, 57.2%, had heart failure as a complication in the first admission. The incidence of the other complications such as stent thrombosis, ventricular arrhythmia, atrial fibrillation was significantly higher in the not readmitted group. In conclusion, the 30-day readmission rate after ACS hospitalization was 14.9% only. Complications such as heart failure, atrial fibrillation, stent thrombosis, and ventricular arrhythmia were significant risk factors for 30-day readmission. And thank you for listening. Any question? I hope you all hear me.
We heard you very well.
Thank you.
Just listen to the judges, Noura.
Thank you. Yes.
يعطيك العافية نورا. طيب, I have a couple of questions. I might be missed it in the slides, but did you measure the medication adherence for the patients whom readmitted within 30 days? I mean, most of those patients, they've gone PCI, so they have list of 3 or 4 medications they have to take after they've been discharged from the hospital. So did those patients were adhered to those medications, or it wasn't measured actually?
We want, inshallah, in the future to measure this, to measure the adherence for medication. But for this project, we didn't measure that.
طيب, so what was the most reason for readmission?
The most complication was heart failure. It was significant, and after that, followed by AFib, stent thrombosis, and ventricular arrhythmia. But we found after we conduct the logistic regression, are you hearing me?
Yeah, I'm here.
Yes, after we do the logistic regression, binary logistic regression model, that's what was carried out to calculate the odds ratio for all the significant factors. And we summarized that the patient with anemia for the baseline characteristic, and for the complication like stent thrombosis, ventricular arrhythmia, heart failure, it's more likely to be readmitted after 30 days compared to the other patients.
So the atrial fibrillation was diagnosed at the previous admission, or it was diagnosed as the readmission?
At the first admission.
So it wasn't treated, or it wasn't actually, it wasn't given a medication at that time, or it was controlled at the first admission?
For the AFib, they developed after the PCI, and actually they treated those patients with the anticoagulant. But one of our limitations in this study, we didn't collect the data for the anticoagulant. We know كم عدد البيشنتس اللي خذوا anticoagulant, but we didn't know which type of anticoagulant, and but the reason of the use was AFib.
Okay. Excellent. يعطيك العافية.
الله يعافيك دكتور.
Thank you, Nora, for your presentation. I have a question. So you mean the use of these medications in the previous admission? Did they predict if they were, you mean, discharged with these medications or prescribed these medications? Were they?
Can you repeat the question, Dr. Hadid?
This with the complications. Hello? Hello, can you hear me?
Yeah.
So did you get my question?
No, can you repeat?
Okay, so I'm asking the medication that were used, that you talked about, the beta blockers and A's and so on. These are the reflect home medication or discharge medication at the previous admission?
Medication, which is home medication. But يعني there was a good number of those patients, they didn't receive it before. But we didn't clarify this or group with this.
Okay. Do you have information like ACE inhibitor? There is some data that other research that shows that patient discharged with ACS, one of the medication that they might not be discharged with is ACE. You do know why? There is a reason why ACE is lower in some patients, or not given to all patients.
Yes, there were a lot of studies show that the ACE inhibitor reduce the mortality, decrease the reinfraction, and prevent the development of heart failure. So the benefit of ACE inhibitors actually in patients with MI most likely comes from their ability to prevent cardiac remodeling actually.
That's excellent, that's true, but the problem why, it's just a comment, the problem why patients are not prescribed ACE inhibitor at discharge is guidelines do not recommend them at the same level as beta blockers and as high intensity statin. They recommend them at the same level. You know, the guidelines have level A recommendation, level B, and so on. So A's are not recommended in the same level except for patients who have heart failure, hypertension, diabetes, history of these issues. They don't have any of these, they might not be discharged on ACE inhibitors because the guidelines do not recommend them as strongly as the other medications. Keep in mind that there's an issue with these guidelines. Most of these ACS guidelines were published 2014 and 16, and even before that, they were not a lot updated since then, especially in terms of these medications. So that's why I'm just keep that in mind when discussing about ACE inhibitors. There's a reason why it could not, it's justifiable by the prescriber. He could justify and tell you, well, if you go and ask them, they will say it is not highly recommended by the guideline for someone who does not have diabetes or hypertension or heart failure or acute kidney injury. So we did not prescribe for that patient. Or another thing that you might, I don't know if you want to collect or consider in your discussion, is the reason they're not on this medication could be an allergy, could be an adverse event, could be very low blood pressure, so they would take out the A's and keep the beta blocker and so on. So you keep that in your mind why they were not prescribed these medications. Thank you. I don't have further questions for myself.
Thank you, Dr. Noura. Thank you for the judge, Dr. Hadil and Dr. Mohammed. After this topics, we reach the end of the first session. Inshallah, we'll see you soon after the break. Thank you, and thank you all.